Good afternoon, Bonasera or Buenas tardes, everyone. So today is our second lecture, and it was very kind from Dr. mahvash to give us two lectures, and today his second lecture, it's about Y90 microspheres, state of the science. And Dr. mahvash again is a dear colleague and a friend from MD Anderson. He is a professor of Interventional Radiology in the Department of Interventional Radiology, Division of Diagnostic Imaging at the University of Texas MD Anderson Cancer Center. Great colleague. I'm not going to overextend based on his requests to me. His area of interest is Y90, and that's what he does on daily basis in MD Anderson, and that's how he developed like an expertise in Y90. So without further ado, I'd like to ask Dr. mahvash to start the lecture. Thank you, Dr. mahvash, for making it.
Thank you so much, Khaled. Thank you, everyone, for coming. I know it's a difficult time for everyone, and I appreciate people being here. I'm open for questions at the end as well. So let me just get started. So my disclosure again. So very briefly, I'm going to go the outline looking at the different devices, the history of the use of the devices, some data, some newer studies that are ongoing and that are current, and then some ongoing studies, and just a quick conclusion. So as I showed yesterday, hepatocellular carcinoma is obviously a very high leading cause of death in the world, increasing in the United States as well. Historically, it's been due to endemic hepatitis, but in the United States, non-alcoholic steatohepatitis has become the second cause of liver disease and the cause for HCC. A lot of our patients actually are coming in with NASH. So these are kind of all the different therapies that are available. I'm just going to focus today on SIRT, which is selective internal radiation therapy or radioembolization. I put it in the palliative setting, but you actually can give it curatively, and we'll show cases like that as well. In the guidelines, again, if you see local regional therapy, they don't distinguish between all the different arterial-directed therapies, as we discussed yesterday. Yesterday I kind of discussed all of them. Today I'm just going to focus on Y90 itself. Again, this is for also not transplant candidates. Again, it's the same local regional options. In the Barcelona Liver Clinic guidelines, there is actually no radioembolization, no SIRT at all. It is not part of their guidelines. Interestingly, depending on who you talk to, it could actually be present in the early stage ACC, intermediate, and late. So you could actually apply it, and I'll show you our guidelines because we actually apply it in all of the it's one of the optional therapies. So in early stage ACC at Anderson, we consider radioembolization. You can see here is one of the options, in addition to ablation, which is preferred in TACE. In addition to greater than 3 centimeters or multiple lesions, radioembolization is there. Single solitary large tumors, multifocal disease, and then with portal vein tumor thrombus systemic therapy with or without radioembolization. But there's some caveats to when you use it with PBT. So just to go over again, why do we do transarterial therapy? How is it even feasible? It's because the portal venous supply predominantly provides the normal liver supply, and the hepatic artery supplies the tumor. And again, the indications, as we discussed yesterday, non-surgical, not amenable to ablation, and then downstaging and also palliation at times. These are the kind of transarterial therapy options. I'm just going to focus again today on the radioactive microspheres. They're non-embolic or microembolic. So this is actually the first clinical paper that was presented in 1989. So it's a little while ago, but still in the, not in the history of medicine, it's still, relatively young. And so this was done, Dr. Gray actually was a colorectal surgeon, and he developed these microspheres with one of his colleagues in Australia to treat metastatic colorectal cancer. And the first study was done is actually, these were done by open laparotomy with the cannulation of the gastroduodenal artery and injection of these microspheres, and then using a probe on the liver itself to decide when to stop. And they showed some nice results in terms of decrease in CEA And so this led to other studies using the resin microspheres, which is called Surrogate. This is actually the first study that was done for the glass microspheres in the United States. This is actually done at University of Michigan as a dose escalation study, and based on this study and other studies, they got an indication in the United States for HCC, for the glass microspheres or TheraSpheres. Essentially, what patient you're going to choose for any of these therapies, regardless of the device, is they have to have a reasonable performance status. The life expectancy, again, they need to be at least 3-month life expectancy. Bilirubin less than 2, unless you're going to do very selective therapies, say in a single segment. And contraindications include elevated AST and ALT. And in general, less than 70% is the standard, but usually less than 50%. As you get above 50%, sometimes it's very difficult to get adequate treatments. And you have to have adequate liver function in general. Some people are treating Child-Pugh B8, but they generally don't do that well because of their poor underlying function. And adequate lunar function to get to have an angiogram. So again, what is radioembolization? What is selective internal radiation therapy? It's a radioactive microsphere that are, depending on which device, they're between 25 and 35 microns in size. So you can see the human hair on the left side. The hair is about 100 microns. These are about 1/3 or half the size of a human hair. They're trapped in the distal arterioles, and they emit beta radiation, which damages essentially DNA replication. Up to essentially most of the energy is deposited in the first 5 millimeters. So the good thing about that is that you can essentially send the patient home because the beta radiation doesn't penetrate beyond the capsule of the liver, or definitely not beyond the skin. So they're not a harm to anyone else. The bad things is that you have to get the spheres to the area of tumor. You can't just rely on the 2 to 5 millimeter cloud. You need to get a little bit of a margin for these tumors. There are 2 commercially available microsphere products in the United States. They're actually available worldwide, but in the U.S., Surrogate is the resin matrix, and they're about 32 microns in size, and at 3 gigabecquerels, which is the activity, there's about 44 million spheres at the time of calibration. And then the TheraSpheres, the glass microspheres, again, they are glass, slightly smaller, but not significantly smaller, and there's about 1.2 million spheres for the same activity. But they have slightly different indications in the U.S. They're approved for colorectal cancer with intra-arterial FUDR, which is no longer done anywhere, but that's the indication. And in TheraSpheres in the U.S. has a humanitarian device exemption, which is a very special exemption for essentially orphan products for orphan disease for HCC. So this is the actual FDA indication for both devices. So for Surrogate, you can use it off-label as long as you tell the patient you're using it off-label. So even when you use it for colorectal cancer in the U.S., you're not giving adjuvant chemotherapy in general. You're not giving intra-arterial FUDR. So it's essentially always off-label use in the United States. And for us, we always tell the patients, and it's in the consent, it's off-label use of the device. We can use it for any variety of neoplasms. Obviously, colorectal is the indication, HCC, neuroendocrine tumors, breast cancer. I mean, it's been used for many, cholangiocarcinoma. TheraSpheres itself was approved in 1999 under the humanitarian device exemption, and essentially it requires the use of a protocol at every institution that oversees the use of the device in the U.S. Now, outside the U.S., the rules are a little bit easier, and so they don't have this IRB oversight required. But for the use of TheraSpheres in the U.S., you must have an IRB protocol that's with oversight. What are the absolute contraindications to therapy? Just very briefly, if you deposit the surrogate on the surrogate day in the gastrointestinal tract, you need to make sure that you don't deposit the actual treatment anywhere in the gastrointestinal tract. So you can have many gastroenteric collaterals that exist that you need to identify and embolize or bypass on the day of your treatment. The absolute contraindication is elevated lung shunt greater than 30 gray at a single session, so you cannot overdose the lung to minimize the risk of radiation pneumonitis. General relative contraindications include complete occlusion of the main portal vein. In general, those patients have historically done very poorly anyway. And then compromise of the ambulovator is a relative contraindication, recognizing there is increased risk of liver abscess. So what's the treatment planning? Why do we even make a plan? Let's think about how I plan a patient. So you can kind of look at how you want to look at each patient. Do you want to try to cure them of their disease? For instance, if they have small enough disease burden, you can actually give them adequate treatment to cure them. Palliate them in general, that's what we are doing for most patients, and potentially downstaging patients for liver transplant if possible. We need to obtain, obviously, reproducible results in different patient populations. And the safety of the liver and the lung are very important. Liver in terms of your underlying liver function after treatment, and be able to, and lung, minimizing the dose of the lung greater than less than 30 gray at treatment session. These are kind of how I look through when I do a procedure. I look through the patient's history. The patients will many times be discussed at multidisciplinary tumor board or consultation directly with the patient after discussion with the referring oncologist. We'll look at their history, what chemotherapy they've received, what their labs are, pre-procedure imaging, and obviously what's the goal of treatment? Are we trying to, what are the goals of this therapy? So you can give an honest discussion to the patient when you're seeing them in clinic. I can tell patients, my goal is to try to palliate you. I cannot cure your disease at this extent of disease, but or my goal is to cure you, and that is that is the plan. We do imaging obviously during the planning stage. We also then use that imaging for dosimetry, which we'll discuss briefly in this talk. Dosimetry is kind of the new part of Y90 that really is really exploding in terms of its research and its application to patients. And then obviously we use it for therapy. Imaging is used for therapy delivery and then verification of your delivery. And then we use that imaging to look at response evaluation. So imaging is critical throughout the entire process. What's very important is that you do some cross-sectional imaging before you come for the procedure. You can use contrast-enhanced CT or MRI. Honestly, my personal preference is contrast-enhanced CT only because of its excellent spatial resolution. It allows for you to recognize extrahepatic collaterals before you start the procedure. But MRI is obviously also useful. It just unfortunately limits some of the evaluation of extrahepatic arterial supply, which exists in a significant number of patients. Also, functional imaging for colorectal cancer and neuroendocrine tumors are also used. So it's a 2 outpatient session procedure. So it's 2 separate days in general. There are some places in the U.S. and outside the United States doing these in a single session, single day. We happen to be one of them. There's just a handful of places that are doing all of this in one single session, one single day. But in general, it's generally a 2-day procedure as outpatients. So basically, you are mapping the patient's hepatic arterials, as well as any extrahepatic vessels that may be in the field of treatment. You embolize those if you need to. You inject a surrogate, which is technetium 99 MAA as a surrogate at the site that you plan on delivering your treatment. The patients then go to nuclear medicine to get an evaluation of the lung shunt to make sure that you're not going to deposit too much of the radioactive microspheres into the lung as they bypass the liver, and assess for the perfusion of the tumors for dosimetry, and assess for any extrahepatic. If you have some of the MAA, the surrogate, that you see in the stomach, we need to figure out why did the activity end up in the stomach. It should not obviously be in the stomach, or duodenum are the most common, or pancreas. And then the patient comes back for a second day for the actual treatment. Again, we repeat the catheter angiography. Not as the details have already been delineated on the day of the diagnostic portion, but then get to the site you want to deliver your treatment, and then we do post-administration imaging, either SPECT CT, which is the standard mostly in the United States. In Europe, a lot of people are doing PET CT, because that's kind of where we know that we deposited our activity in the tumor, and I'll show you some images of what we do. And then obviously the patient has to come for follow-up. Everyone has a different paradigm for following patients. Some patients get followed at 1 month imaging. We do not generally do that because you don't really see any change in the tumors at 1 month. You really start seeing changes at 2 to 3 months, and then for months they're out. So some sites do 1 month post-procedure imaging, but there's no expectation of response at 1 month. So we generally bypass that and just go to the 2 to 3 month post to start looking for early response. Why do we do catheter? Why do we do this? Again, we need to avoid complications, and the thing we talked about before is the risk of depositing your activity outside of the liver. In the current kind of climate, realistically, this is some old studies back in 2010. people are still having 2.6% of patients developing ulcers. Realistically, in a good practice, this should be less than 1%. As long as you're utilizing all of your available imaging, it's very important to do your diagnostic, obviously, angiography, but most important in this modern day is to use in-room cone beam CT, which I think I've showed you yesterday. I'll show you some images today, or the in-room CT angiography, which really facilitates the understanding of where you're depositing your device, and make sure you're covering the tumor completely. So what is cone beam CT was first developed in the mid-2000s, basically a rotational angiogram, which gives you a 3D image of the liver. We actually use it a lot of times to look at it as our baseline imaging, because there may have been 6 weeks that have passed between the time of the diagnostic imaging and the time of the treatment. So we may see that the patient has progressed in the interval, so then it becomes the new baseline. If you look in these patients' imaging folders, there are usually a lot of places doing Y90 or doing cone beam CT. And clearly, as this paper from 2009 shows, that it does affect your treatment. So it's very important to use it in the therapy. Really briefly, I want to talk about dosimetry models. So the left model is the model called single compartment, is the way that we historically looked at how the Y90 itself distributed into the liver and tumor compartments, assuming that they were uniform. But honestly, that's not the truth. The truth is probably on the far right, on the far right-hand side, which is the realistic model, which has different uptakes in the tumor and the normal liver. And a simplified version, which is close, is the middle model. It's called the partition model. And that's the model that we use in most cases, and occasionally use the model on the left. Essentially, there's software that can help you do these things, and that's where we have, the field has evolved realistically in the last 5 years to kind of slowly, hopefully, abandon the left model and move toward the middle to the right model to give better patient outcomes. And I'll show you some of the recent data. So here's just another graphical representation. You can see this is the same tumor. If you consider all the 3 different models, there's 2 different tumors in this patient. And if you assume the standard model, it's uniform, it's clearly not. Partition, which means that both tumors are the same and the liver is the same. And then the ideal model, or the true model, is called voxel-based dosimetry. And it basically shows that the one tumor has one uptake and the other tumor has a different. You're giving brachytherapy, you're giving radiation therapy. And the key to this therapy is that you're actually delivering a dose that will cure or kill the tumor. It's very important that we deliver the right dose to the right location. And so this is, as you can see, one tumor is here, and obviously it's not getting the same dose as this tumor. And actually here's a graphical representation of what happened. Tumor 1, which was the small tumor, got a much higher dose, and this tumor actually had a complete response. And this tumor, the big tumor, actually got a lower dose and only was stable on post-procedure imaging for out to about a year, and then we retreated this patient appropriately. But again, you need to achieve the right dose to the tumor. It's just like radiation oncology, but we need to do that in terms of radiation and interventional radiology and nuclear medicine. This is a study out of UCLA just to show that this was published just 2 years ago, and showing that as long as you reach the threshold of 200 gray, this is with glass microspheres, so the devices are a little bit different. 200 gray would give you 66% sensitivity and 100% specificity to response for the patient's tumor. They also published a separate paper looking at what dose to the normal liver. So we want to get 200 gray to the tumor. What dose to the normal liver causes toxicity? And essentially what they showed is that above 54 gray, they had increased toxicity. The patient's once the normal liver achieves greater than 54 gray, then you're talking about grade 2 and higher toxicities. This is our paper from Anderson that we published also in 2018, which shows there's a dose response curve. It's not a straight line as kind of described. You have some people that these are the non-responders, that even some people at higher doses don't respond, but then you have some low responders. But this is the data that fits this is the curve that fits the data that's there. And our mean dose for response is a little bit lower, 160 gray. But interestingly, the dose that caused complications for us was 50 gray, so very similar, 50 to 54 gray. So the rate of complication was significantly lower below 50 gray. So those are good numbers that we use in our actual clinical practice. So this is an interesting paper from 2015, I believe, that talks about dosimetry to tumor and response. So this is about 5 years old, but people have kind of finally caught on to it. This is out of a group in France that looks at dose to the actual perfused tumor and looking at response. And what they show, this is just an example case. You have this patient with portal vein tumor thrombus and tumor here, and then they have administered the surrogate particle, and as long as you can confirm the surrogate particle on this nuclear medicine image is being deposited in your tumor, and then you deliver in a similar location, you can see in this case, you can have complete response of tumor in the portal vein. And the estimates of survival and progression-free survival shows that if you get over 205 gray, that's their number, 205 gray is this line, versus less than 205 gray is this line in terms of progression-free survival. And then clearly in the overall survival category, you can see that there's a difference in the survival depending on if you achieve an adequate dose to the tumor. And that's really the key to how Y90 works. You have to achieve an adequate dose to the tumor, just like they would do in radiation oncology with external beam. Very briefly, this is for early HCC. These are generally BCLC-A patients. These are this is a study out of Mount Sinai that looked at small lesions up to 3 centimeters that were not amenable to TACE. They got Y90 segmentectomy, basically ablating that single segment, versus patients that were matched that got TACE and microwave, looking at the responses and overall survival. So their complete response rates were very similar in 2 groups, and their overall survival was very similar. Progression-free survival is very similar in 2 groups. So even with, you can use it in the early, right now, if you look at this as the MD Anderson algorithm, ablation is first, TACE with ablation, and radioembolization. So in this group, they actually looked at the 2 groups, and you can get very nice results in small tumors. This is another study out of Northwestern with Mount Sinai combined patients, and they looked at selective, so tumors less than 5 centimeter, not amenable to RFA, and they looked at dose to tumor and what doses they would get responses. And essentially, they got the number was 190 gray. That's their number, so at least 200, which is described in the other papers. And they actually transplanted some of these patients, 102 patients, 33 who got transplanted, and half of them had complete pathologic response, and the other half did not. But it's just a good, there's a paradigm of you need to get enough dose into these tumors, you can get complete responses. This is a patient that I did several years ago. This patient had a solitary, very central HCC, not amenable to resection. And this is just the in-room cone beam CT, which you can see this is not a very vascular tumor. And it had actually 2 separate feeding vessels, one here and one here. Those are the only 2 feeding vessels to the tumor. And on the day of the diagnostic, we were able to inject one vessel selectively, the other vessel we were not. But what happened was part of the tumor has a very nice uptake of the surrogate. This other half of the tumor does not, because I could not directly get into this vessel. But on the day of the treatment, I was actually able to get my catheter in the vessel directly. And over here, this is the other small vessel I was not able to catheterize on the day of the diagnostic. And now you can see you have complete coverage of the entirety of the tumor. This is the post-administration image showing where your radiation actually is. And this is him 2.5 years later. This is that original tumor with a very nice, essentially complete response, 2.5 years post-procedure. So this is an interesting case that I did several years ago with a patient with elevated bilirubin. Bilirubin was 2 due to obstruction of a central mass causing an elevation in the direct bilirubin. Patient was not a surgical candidate with her portal hypertension. Platelets were decreased, otherwise elevated AFP and a low albumin. So this is just the diagnostic MR, just to show you really briefly what we were dealing with. There were small lesions in the right liver, but the dominant lesion was here. You can see at the bifurcation of the left and right liver. She had intrahepatic biliary dilatation causing her elevated, and you can see here, you can actually see the dilated biliary tree on the right lobe. So in-room CT imaging, this is the imaging we do in the room. You can do cone beam CT. In our case, we did in-room CT angiography. It's very helpful to know what the baseline size of your tumor is on the day of your treatment. So you can see the size of the tumor in 3 dimensions here, and this is what this was the goal of treatment. So the patient had essentially 2 different right lobe and partial left lobe supplied to this tumor. this is how we do the planning. There's some software that we use to map out the volumes of treatment and to help calculate the dose to these volumes. I won't go into the details, but I'm saying there's software to help you. You take and import these images into the software and you use volumes of calculations, uptakes to calculate dose. And essentially on the day of the treatment, you need to image them. This is the day of the treatment after you've administered the dose. And you can see that it is focused in the tumor itself. And this is her on follow-up, 3, 6, and 9 months. And the initial size of the tumor, if you can remember, was significantly larger. And as you look over time, tumor at 3 months is starting to get smaller, and continues to get smaller at 9-month follow-up. She did start on low-dose systemic therapy. She has also developed new lesions in the left lobe. But after being on low-dose systemic therapy, she went on immunotherapy for a short period of time. And essentially now, 2.5, 3 years after follow-up, you can see this is what her AFP was at the time of her treatment, was elevated, and then eventually came down to normalize. And this was her bilirubin at the time of treatment was 2, which is obviously elevated, but as the tumor shrunk, her direct hyperbilirubinemia resolved and her bilirubin actually became normal. And at 30 months, this is her follow-up image, she's not cured of her disease, but clearly we had a very nice response of the treated tumor. And with the combination of systemic therapy, there was also able to treat the other small lesions that were present. This is a study, this is just a study that was a cohort of patients from Northwestern that they used glass microspheres there. Again, I just want to show that in different groups, BCLC A, B, and C, this is their survival. And in resin, this is out of Europe, this is out of Barcelona, the BCLC A, B, and C patients have very similar survivals. So people kind of argue between the two different devices, but the reality is the two different devices have very similar outcomes if used properly. This is a new paper out of the Northwestern group. They actually looked at 1,000 patient cohort using glass microspheres for HCC. This is the largest study ever published for radioembolization in HCC, actually in any disease entity. And so they categorize their patients. They have large groups of BCLC A, B, C, and D patients. We generally don't treat BCLC D patients in our population because they're usually toward the end of their life expectancy, and then divide them up between Child-Pugh A and Child-Pugh B. So it's very interesting. In a BCLC A patient, their median survival, if you're a Child-Pugh A with BCLC A, so solitary, is 47 months, which is actually very similar to resection in this very kind of tight patient cohort. You do have some toxicity, grade 3, 4 toxicities long-term, albumin and bilirubin. Some of these are declines just due to the fact that the patient has underlying liver disease. Some of them can be attributed to dose to the normal liver. So it's hard to distinguish the two because some of these people are in decline because they have underlying liver disease. Some of these have a decline due to their dose to the normal liver that you're treating as well. This is just the survival curves, and you can look at T1, T2 tumors, so small tumors, Child-Pugh A, your median survival here, you're on the order of 4 to 5 years, which is what you can get with surgical resection. This is in BCLC-B. Again, this is generally multifocal disease. Their median survival in this group is around 24 months, which is around what they have in the BCLC C algorithm that was shown above. TASTE gives around 20 months, so they're about very similar in their efficacy in large patient populations. And this is BCLC-C. These are advanced either mostly with portal vein tumor thrombus or with decrease in performance status. There's a couple papers on the use of microspheres in the setting of portal vein tumor thrombus. There were some questions yesterday. So this is out of the Italian group looking at patients with portal vein tumor thrombus, and I'll show another paper in a moment. This is the patient with tumor thrombus, this is the patient without, so there's slight difference in their survival, but technically it was non-significant. But in general, obviously it depends on how you dose these patients in stratification, but I'll show another study. This is a study that was done in France a couple of years ago. It was a prospective study comparing Y90 to sorafenib, which at that time is and it's still kind of at the level of standard of care for non-resectable, essentially 8 BCLCC patients, advanced CC. So basically, the patients were randomized 1-to-1 throughout France. And essentially what it showed, unfortunately, is that there was no true benefit in survival when you were treating patients with CERT versus sorafenib. What was interesting, unfortunately, a lot of patients didn't receive their therapy due to many different reasons, but ultimately it was a negative study. The one thing that was positive, it did have better quality of life for the patients that got the CERT therapy. So since it was a prospective study, you could collect this data, and they did show improved quality of life in those patients, even though there was no improvement in survival. This is another study. This was done in Asia. Similar study, Y90 versus sorafenib. Again, no benefit in overall survival. And there's a third negative study also done, also showed no benefit in overall survival. The problem with all these studies was that they never considered the dose that was going to be achieved into the tumor when they were doing these plannings and doing these treatments. The original study, the SARA we showed you, they did a subset analysis of patients that were able to figure out the dosimetry of the tumors before and after the treatment. And so what this did show, which is very interesting, is that once you achieved at least 100 gray, this is resin microspheres, you had a different survival than when you achieved below 100 gray. So this is the median survival. If you go back to this slide, median survival in this patient population was 8 to 10 months, depending on CERT versus sorafenib. But if you look here, the patients that received CERT and achieved at least 100 gray in the tumor compartment actually lived significantly longer. And what it also showed is patients that didn't receive enough dose actually lived less. So you may have actually been doing harm to these patients. The problem with this patient population was that many of them had already received transarterial therapies and essentially TACE. And TACE, the method by which it works is it occludes the blood vessels. And occlusion of the vessel prevents you from delivering another therapy later. And that's why I think, and if you look at this patient population, you probably had patients that you weren't actually delivering your therapy to the tumor, and actually you were delivering radiation to the normal liver, causing a worse outcome than actually getting the drug by itself. So this is actually a huge study that was just finished and just presented at ASCO. The paper has not been written, but it was presented at GI ASCO this year. This is a prospective dosimetry study done in France in a multi-center institution. It's a huge, I think, a paradigm shift forward by the same group, Dr. Gurin, who wrote the other paper I described, looking at the standard method of dosimetry, 120 gray to the entire compartment, versus actually doing advanced dosimetry, 205 gray to at least a minimum of 205 gray to the tumor, and for all tumors greater than 7 centimeters. So the primary endpoint was response, and then secondary endpoints were present. This is just the consort of the diagram, and this is the actual primary endpoints. If you look at responses, were much better in the higher dosed group here. Overall response was 71% versus 35%. And the dose to the tumors were also higher, which intuitively makes sense. If you reach higher doses to the tumors, you will get better responses. And they had very similar adverse events in the two groups. So that's an important caveat. This is a randomized study that was done at Northwestern from 2009 to 2016, and they published their results in 2016. They randomized patients to standard arm conventional TACE versus the treatment arm, which was Y90 glass microspheres, and they looked at time to tumor progression. And so in this group, it is a single center study. It was initially started as a multi-center study, but eventually the other centers dropped out due to recruitment issues. And so the only site that was able to recruit was a Northwestern study. But as you can see, the time to progression, and these are all patients that were trying to go for transplant, but time to progression in the Y90 group was longer than time to progression in the conventional TACE group. This is the only randomized study that was done with conventional TACE versus Y90. There was a small study that was done in Europe that was conventional, that was drug-eluting bead TACE, that was even much smaller than this group, that showed no benefit. But I think the issues are that it depends on the patient's population that you're selecting in these groups. But in this case, this is a single center randomized study showing some benefit in time to progression. Now, there wasn't a benefit for overall survival, But you have to understand there's only 40-something patients in this patient population. If you actually do a study to determine overall survival, you need a minimum of 300 to 350 patients in any study to prove survival benefit. So any study that has below that number can honestly not show you survival benefit. So it's just the nature of the statistics required to do survival benefit studies. So in their standpoint, this is Y90 versus TACE as a single center randomized study. They basically said that in their standard, Y90 should be their standard method for bridge to transplantation, especially in a very selective segmentectomy technique. And for Northwestern, that is their standard of care now, and that's what they do for all patients. This is another study. I want to talk a little bit about dosimetry again. This is we answered some questions yesterday about portal vein tumor thrombus and treatment with Y90. So this is Dr. Gurin again. He's done a great amount of work looking at dose to tumor and surrogacy. And so this is a study that was published a couple years ago looking at personalized dosimetry to areas of portal vein tumor thrombus and looking at their survival. And so again, looking at the outcomes. So patients that you can see this is the overall survival curve is fine down here. You look at tumors that received more than 205 gray, significant difference in overall survival. The issue is that sometimes you can't achieve 205 gray safely, so that's a very important caveat. So you're kind of selecting patients. So sometimes when you can achieve this, you can have very nice results for patients with PVT, but the key is that you have to select these patients very carefully. But at least we know that we need to achieve certain doses in tumors to get better results in patients. So adverse events we talked about a little bit yesterday. It's an outpatient procedure. Post-embolization syndrome is very rare, about 5%. The other issues are very, very uncommon. The issues become long-term liver dysfunction. So all this depends on the dose to the normal tissue, which we showed in the two papers I discussed earlier. You need to minimize your dose to the normal tissue if possible, and obviously preserve liver that is not being treated to maximize long-term benefits without causing adjacent toxicity of the normal liver. So it's very important. In the last study I showed, the study from the randomized study about 2 dosimetry models, they made sure that 30% of their liver did not receive Y90. So if you have diffuse filobar disease, it can make it very difficult to treat people with radioembolization, but not impossible, as long as you keep doses, normal liver doses below a certain threshold. I'm just going to show a quick case of a patient I treated actually about a year and a half ago, 2 years now. So he is a patient with NAS cirrhosis with solitary HCC in segment 8 and PVT extending into the right main portal vein. His AFP was elevated at 13,000, and the recommendation was him to come for Y90. So this is his pre-procedure imaging. This is the MR. You can see he has this right lobe HCC right here, you can see, and there's extension of the tumor as we come down into the right portal vein right here. You can see the enhancement. And then this is the CT image of the same patient, and you can see the tumor extending into the right portal vein right here. You can see the extension into the right portal vein. So we did in-room. This is a diagnostic angiography. You can actually see this is in the room. This is an in-room CT, and you can see the tumor on the early arterial and late. You can actually get 2 phases at 1 injection, and you can see extension of the tumor in the portal vein at that time. We happen to do it. It's very important, actually, I think, to do the in-room imaging so, to make sure you've covered everything. What we didn't realize on the first injection that there was actually tumor being perfused from the left hepatic artery, in particular segment 4, to this margin of the tumor right here that we wouldn't have seen had we not done this in-room imaging. You would never detect this. It'd be impossible to detect it on just plain angiography. This is the surrogacy. We wanted to make sure that, hey, did our treatment end up in the tumor this is the surrogate day. This is the day of the surrogacy, and we see we have activity in the tumor itself. And then this is the actual treatment day where you see where we plan on giving the treatment. You see uptake in the area of tumor, extending into the area of the PVT, which is up a little bit higher. And this is his first follow-up at 2 months. And so what we see at 2 months is that you see lack of enhancement and actually some retraction of the PVT that was present on the original diagnostic imaging study. And this is him at 1 full year after treatment. We have some atrophy of the area of treatment, but you have lost, the PVT is retracted and no longer enhancing, and he actually is now a transplant candidate. He is on the transplant list at one of the transplant centers right across the street from our center. So since he's been without and basically response and without any enhancement of any tumor for a year, he is now on the transplant list. So you can, patients that were ineligible for transplant, it's possible to downstage them to transplant. And you can see, actually, it was very interesting. This is the day of his treatment here. When I asked him what had happened between this day and this day when I met him, he actually told me that he had become a vegetarian. And he is not on any systemic therapy. So clearly something to do with his diet made a significant difference in his AFP. And this is our day of treatment. And now this is AFP out over a year now. So he is, some of it I think some of it may have been from the Y90, but there's obviously the patient lifestyle has had something to do with his response as well. This is my last case I want to show. This is not HCC, but this is kind of the advanced method of doing advanced voxel-based dosimetry on a patient with metastatic disease. This is 3 months prior to the Y90 imaging. This is 3 weeks prior. You can actually see significant progression in between these two imaging studies. And the patient actually came on the day of her diagnostic angiogram, and her tumor had even progressed even further on the diagnostic angiogram. This is the cone beam CT. The 3 tumors that you see here have even progressed even farther than you saw just 3 weeks earlier. But the key was that we gave her the surrogate, using that as a template for us to do the dosimetry planning for her. We did advanced dosimetry for her, trying to maximize the dose to the tumor, knowing that we had the left lobe that was spared, so we knew that we would not be treating any of that territory and try to maximize the dose to the tumor. And we used some advanced software to calculate planning volumes and dose to these volumes. Essentially gave her a treatment, and this is a confirmation image of the treatment. The treatment is actually at the site that you planned. I think it's very important to always image patients after and confirm, did I actually get the treatment where I planned on getting it? And this is a DVH curve, dose volume histogram. I showed one yesterday. This is for this patient. She had 3 different tumors. These are her 3 different tumors. And what we showed is that we wanted to reach at least 100 gray median dose to each one of those tumors, and we did. Her normal liver got lower than that. So this is the dose volume histogram for her individual tumors. Each tumor has its own dose response, but we achieved the median dose they want to. And this is her at 2 months. So 2 months later, she hasn't changed significantly in terms of size. It's first, you see lack of enhancement. But this is her at 1 year, and this was her at 3 years post-therapy. She has essentially complete modified resist response. These are all her tumors here. They've all disappeared. And her left lobe was hypertrophied because we atrophied her right liver. She ended up living for 3.5 years, and she had no more metastatic disease to the liver, but unfortunately, all the prior chemotherapy caused her to have myelodysplastic syndrome, and she passed away from myelodysplastic syndrome. Very briefly, there are 2 ongoing studies with glass microspheres that are closed. They are closed, and now the data is being finalized for publication. One was glass microspheres for colorectal, glass microspheres for HCC. Unfortunately, neither of these studies used dosimetry, so my concern both of these studies is neither study used advanced dosimetry techniques, so we unfortunately may have another series of negative studies. Anyway, very quickly, briefly, conclusion. So Y90, the studies that I showed, Y90 resin with or without sorafenib was not superior to sorafenib for patients that had, for overall survival. Those are the 2 studies that were negative. It is shown, though, that Y90 has fewer adverse events than sorafenib alone. We have it also has improved tumor response compared to systemic therapy by itself. You could argue saying 1 therapeutic session of Y90 may be better for a patient overall than getting a systemic therapy, but that wasn't the goal of the study was to have a better outcome, and they didn't have that. This randomized study, the 4th bullet point, was a randomized study done at Northwestern, showing that there's improved time to progression compared to conventional TACE for transplant patients. And then in terms of absorbed dose, the 2 devices are different. So for resin, absorbed dose greater than 100 gray definitely shows improved survival compared to less than 100 gray. And for glass, the responses greater than 205 gray are significantly improved survival when compared to less than 205 gray. That's it. If there's anything else, please ask questions. Thank you. Thank you.
You can tell that the clapping are coming from different sources, right? So thank you
so
very
much.
much, Armeen. That was a very, very nice lecture. We really appreciate that. It really tells me that, and I even got the feedback yesterday when I posted your lecture, the recording, that a radiologist from, or interventional radiologist from Case Western told me this is really important to indicate the difference between particularly Y90 and other local regional therapy because of the frequent misinterpretation of the follow-up of Y90. So it's not a good radiologist who don't really understand the different therapies. So thank you very much for elaborating on that.